Picture this. A 60-year-old man is talking to you in the ward. Suddenly, he grabs his chest, collapses, and the monitor shows a zigzag line, wide, fast, scary. You check for a pulse? None. This, my friend, is Pulseless Ventricular Tachycardia, or VT for short. In simple words, the heart is still electrically active, but it's pumping too fast and too uncoordinated to move blood. So even though it looks alive on the screen, the body's not getting any blood. Here's a question for you. If the monitor is showing activity but there's no pulse, is that a cardiac arrest? Yes, because cardiac arrest means the heart isn't generating effective blood flow no matter what the ECG shows. So what do? Rule number 1, don't stare at the screen. Start CPR immediately. Push hard and fast, 100 to 120 compressions per minute, 5 to 6 centimeters deep, and let the chest recoil fully after each push. While you're doing compressions, someone else should grab the defibrillator and attach the pads. Don't wait for the doctor, don't wait for confirmation. Time is life. Once the pads are on, check the rhythm briefly. If it's VF, ventricular fibrillation, or pulseless VT, it's shockable. Give one unsynchronized shock right away, typically 200 joules biphasic or 360 joules if using an older monophasic defibrillator. After the shock, immediately go back to CPR for 2 minutes. Don't pause to check anything yet. After 2 minutes, pause for less than 10 seconds to check the rhythm again. Avoid long pauses. That's one of the most common mistakes. Now, airway management. Should you intubate right away only if you're skilled and it won't delay compressions? Otherwise, continue CPR and shocks first. Once CPR is running smoothly, you can intubate or use a supraglottic airway. Ventilate once every 6 seconds, but keep compressions continuous. Never stop CPR just to intubate. Remember, oxygen helps, but circulation saves. Now the medications? Timing is critical. First, adrenaline, 1 milligram IV or IO every 3 to 5 minutes. Give it after the first shock. Don't delay CPR to push drugs. Second, amiodarone, 300 milligrams IV bolus if VF or pulseless VT persists after 2 shocks. A second dose of 150 milligrams can be given later. Third, if amiodarone isn't available, use lidocaine, 1 to 1.5 milligrams per kilogram IV. And sodium bicarbonate? Only for special situations, hyperkalemia, drug overdose, or an arrest lasting longer than 10 minutes. Here's a common mistake, giving all the drugs together or stopping compressions while giving them. Never stop CPR for drugs. Keep the compressions going. Now, quick quiz. When should you give the first dose of adrenaline? Answer after the first shock while CPR continues. So, pulseless VT. It's fast, it's chaotic, and it's fatal unless treated fast. Your sequence should always be CPR, shock, drugs, and minimal interruptions. Each second you save could mean a life saved. CPR and shocks keep the body alive, but you also need to fix why the heart stopped. We remember that with 5 H's and 4 T's. First, H's. Hypoxia, lack of oxygen. Hypovolemia, low blood volume. Hypothermia, hypo or hyperkalemia. And hydrogen ions, that is acidosis. Now, 4 T's, tension pneumothorax, tamponade, pericardial, thrombosis, heart attack or PE, and toxins. Question, which of these can you treat immediately? For example, if you see distended neck veins and absent breath sounds on one side, think tension pneumothorax, needle decompress now. See it in your mind until your hands move automatically. That's how real pros think in a code. Join the E-Pulsepoint app and see you in the next one.